Okay, our presentation was case number 7, and it was a 58-year-old with hemiplegia, and this presentation was by Allison Warsinske, Sarah Cameron, Jon Kevnick, and Jen Rawski. So the background information for Marc Holliston: he's a 50-year-old stockbroker, and he recently was admitted to the hospital with the CVA in his right middle cerebral artery. Before this event, Marc had a substantial past medical history. He has angina, AFib, hypertension, and insulin-dependent diabetes mellitus. 3 years prior, he also had a hernia repair. And Marc has been a 1 to 2 pack per day smoker for 42 years, and he's unable to quit smoking despite several attempts by the healthcare professionals. The current medications that Marc is on, he is taking insulin for his type 2 diabetes. He takes nitroglycerin as needed for his angina, and he's taking catapress to help alleviate his high blood pressure. His current medical status, he was recently admitted to the hospital for right middle cerebral artery, CVA. He has spent 10 days in acute care, and he recently has been taken into a transitional care unit. He also feels exhausted, and he wants to return to work ASAP, and he's having a little bit of a hard time understanding the severity of his condition. And it also should be noted that Marc has developed a stage 2 pressure sore on his left greater trochanter, so that we took that into account when we were developing a treatment program for Marc.
So Marc has a lot of body structure and function issues going on. He's hypotonic in both the left upper and lower extremities, as well as his trunk. Marc has a sustained clonus in the left ankle. When they tested his sensation, it was severely impaired. He had a 0 out of 10 correct responses when they tested proprioception, light touch, pain, deep pressure, hot or cold. Marc currently is in no pain. He also has displayed left-sided neglect, as well as diminished strength in the left side. His trunk muscles are a poor plus to fair plus bilaterally. He has a trace response in his scapular abductors, adductors, and elevators. He has no response in any other muscle on the left side of the body. They were all 0s. So currently he's in Brunstrom stage 1. Marc's sitting balance was also examined. It was poor, and he was unable to sit without maximum assistance, so therefore his standing balance was unable to be examined. He also has moderate edema in both his left hand and foot, and although he has passive range of motion throughout his body, he has no active range of motion on his left side due to his diminished strength. He also has numerous activity limitations. He's unable to sit at the edge of the bed without maximum assistance ×2. Marc is unable to roll, bridge, transition from supine to sit, sit to stand, and he can't transfer from a bed to a wheelchair, chair to the toilet, or transfer to the tub or shower without maximum assistance ×2, as well as he needs maximum verbal cueing. Marc currently has a wheelchair, however he needs total assistance to be able to propel it, and currently he is unable to walk. There are many self-care activities that Marc is limited in. With feeding, he needs complete setup. He has poor lip closure. He pockets his food. He has max assist when it comes to bathing with his upper body washing, and he also presents with left-sided neglect. With grooming, he attempts to comb his hair and brush his teeth and shave, but he's impulsive and again sometimes forgets the left side of his face. With dressing, he needs maximum assistance with max verbal cueing for his upper body dressing. It's done in supported sitting, but he's completely dependent in lower body dressing and he has to be supine. For toileting, again, he's maximum assistance and he uses a urinal and a bedpan. For his cognition, he also has activity limitations for this. He has impaired short-term memory and immediate recall, which affects his ability to follow directions. He has impaired sequencing, which impacts his ability to do activities that cross his midline. He has poor judgment, which affects his ability to recognize his current deficits. And he also has poor problem solving, concentration, and attention affect, which affects his ability to do his independent ADLs. Due to all these activity limitations, Marc is unable to participate in a lot of different things. His job before this was he was a broker, which was very important to him, so he's unable to continue that work. He loved power boating with his pals, and he can't do that. He liked to attend baseball games where he liked to whoop it up, and again, he can't do that. Marc also has a wife at home, and as well as a son that currently are living with him, so his duties as a father and husband are going to be more difficult. Marc's mother-in-law also lives with them, and she has dementia. And although she's quite physically independent, she still needs supervision. Marc is also having difficulty doing more than one activity at a time, such as reading a newspaper and talking. All these things affect his environment. Some external environment negative factors are that there's 4 steps entering his house, and they don't have a handrail. But there's 6 steps in the back of the home, which do have a handrail, but they're in the back of the home. And again, there's a mother-in-law that lives with him that has dementia. Some positive factors that Marc has for his external environment is that he's a ranch-style home, so he won't have to go up and down stairs to get to his bedroom. There's no architectural barriers inside the home, and then he has a wife and son at home that can assist with his care. As far as how Marc is doing internally, the negative factors that he has a lack of motivation for physical therapy, and then he has a lack of recognition of his impairment. Positive factors is that Marc wants to quickly return back to his job, so hopefully the physical therapist can use that to motivate him.
We have that the patient is dependent in bed mobility as well as all transfers and transitions. He is also dependent in ADLs due to the left side neglect. He also has decreased balance and coordination and is unable to ambulate. The patient is unable to propel independently in a wheelchair. He lacks motivation and compliance toward physical therapy. The patient lacks active range of motion in the left upper extremity and left lower extremity, as well as strength in these extremities in the trunk. So for the plan of care and the goals, we said that the patient will be able to bridge and roll with minimum assistance and no verbal cueing in order to prepare for independent bed mobility and self-pressure release. The patient will be able to transition from sit to stand with minimal assistance and verbal cueing for 4 out of 5 trials in order to gain functional independence and mobility. Third, the patient will be able to independently identify his left side neglect by demonstrating appropriate compensation techniques such as scanning to become more independent in his ADLs. And lastly, the patient will be able to maintain sitting balance at the edge of the bed for 3 trials for 30 seconds to prepare the patient for dressing independently. We also had that the patient will be able to be independent in wheelchair mobility and be able to propel his wheelchair for 500 feet on a level surface in order to prepare for independence in the home. The patient will be able to independently verbalize the importance of physical therapy compliance in order to prepare him for doing an independent home exercise program. The patient's family will be educated in how to assist the patient with transfers so that he can independently do them in the home. Okay. The patient will be educated in how to don and doff the orthotic devices in order to prepare for ambulation. Okay, so there are many interventions that may be done with this patient, and many depend on his presentation in the upcoming weeks. Passive range of motion may be good for the unaffected extremity, and with time can progress to active assisted range of motion and active range of motion. Rude's techniques may also be used to try and facilitate muscle contractions. Stretching may also be beneficial for bilateral extremities due to time in bed and to prevent the patient from developing contractures. PNF may also be used for this patient for a variety of activities. It may help prepare the patient for transitions, and eventually, when he begins to gain strength back, PNF isometrics can be very useful. Balance activities will help the patient with transitions and transfers, can easily be done at the edge of the bed. Coordination can also be done lying down. Modalities such as E-stem may be used to facilitate muscle contractions. Wheelchair training must also be done, and the patient must be instructed on how to go forward and backward, as well as opening doors. For now, the patient may also have to be able to educate others on how to manually push the wheelchair for him, as well as up and down the ramps. So, progression of activities. We would initially work towards restorative treatments, and then with time we would see how the patient will progress, and using clinical judgment we would determine if the patient would need compensatory treatment. So we said we'd progress from NDT to task-oriented approach. Activities can be progressed by reducing manual assistance, reducing verbal cueing, environmental manipulations. Progression will also increase variety and intensity of activities. Gait preparation activities may be done with potential to work towards ambulation, and orthotics and assistive devices may be prescribed, and the patient must be educated on how to use them. Okay, so examples for intervention and progression. We'd assist the patient into assuming bridge position, and then use root technique to facilitate contractions in the left extremities. Use NDT principles to assist the patient in scooting in both directions in bed. We use the NDT principles to assist the patient in rolling in both directions. We could use the PNF techniques on the upper and lower extremities, shoulders, and hips to assist in rolling and scooting. We begin by passively moving the lower extremity and hips. We can use quick stretch to try to facilitate contraction of muscles. We can progress this from passive movement to resistance, as well as isometric contractions for strengthening. When the patient gains enough strength on their own, we can start doing task-oriented approach skills, such as having the patient go to grasp an object to facilitate rolling. Yes.
Consider the interaction of age-related changes. Some things to consider is the motor, spatial, and perceptual memory will be decreased, which will make it difficult to try and retrain different areas of the body to relearn tasks. Also, short-term memory may have to be compensated for with strategies rather than increased. Also, reduced tolerance to sensory conflict may cause difficulty maintaining balance with conflicting signals due to CVA, and you may need to teach compensatory responses. Reaction times may be decreased, which is already just due to the fact that they're aging, and which may make anticipatory and reactive balance difficult, and is increased even more due to the CVA, especially with hemiparesis. The skin is more susceptible to trauma due to thinning and loss of elastic properties, and indicates increased risk for additional pressure ulcers. Some comorbidities affecting the treatment are poor cardiovascular health, which may have difficulty with exercise, especially since endurance has further declined from the hospital stay, so be aware of hypertension and angina. Marc must never exercise without his nitroglycerin tablets. Also, smoking will decrease the healing potential of the pressure ulcer. It also impacts blood flow to muscles and nerves. It may also impact sensation. Type 2 diabetes may have reduced sensation on and may have difficulty determining where the foot is in space due to peripheral neuropathy. It also may have reduced healing potential. Make sure to monitor glucose levels during exercise and ask Mark when he last ate, monitoring for signs of hypo or hyperglycemia. Sedentary lifestyle may also be a factor because the patient was already deconditioned prior to arriving at the hospital and may make activities more difficult because he will already have a limited reserve to begin training and may affect how much one can do in each session. Hypertension is a problem because the patient's blood pressure will need to be monitored during exercise and when changing positions, especially due to the poor cardiovascular health. Also, the patient is on medications for his many different comorbidities, so you should know if they will affect the treatment, when they were taken, how long they will last, and if they cause any nausea or other symptoms. Effects of dependency may be due to the patient being dependent, and it is important to monitor nutrition and hydration. This could affect fatigue, irritability, and falls and balance issues. Here are some psychosocial factors affecting the treatment. One that may influence his rehab potential is his motivation to return to work. This could have positive implications on his rehab in that once he understands the severity of his condition, he will be able to work harder because he will be motivated to return to his profession. Also, if he feels like unable to return to work, he may go through depression as his life seems to be dependent on his job. Also, he is very impulsive right now, which may make the PTs have to be on their toes because they may have to decide to do things when he is in an unstable position, and such as standing or transferring. And this may or may not change with time. Also, he's unrealistic about his condition because he thinks he can return to work right away without complications. He may also be unrealistic about his therapy treatments. The impulsivity and being unrealistic about his condition has made this patient very bitter about his current situation. There's a risk of depression, which is due to being unable to do the activities he enjoys and being dependent on other people. He also has his mother-in-law living in the home with dementia, and this proposes a barrier to rehab potential because she requires supervision, and this can cause a stressor at home. So the son might have to help out a lot more. Also, the wife may have to stop working.
Study that I looked at was on mirror therapy. And what mirror therapy is, it's when you're going to place a mirror in the body's midline in the sagittal plane, and it's going to look like the opposing extremity is in the mirror. Now in the study that I looked at, they decided to use the unaffected extremity outside the mirror, so it looked like the affected extremity was in the mirror, and then the affected was behind the mirror so that the patient couldn't see it, kind of like this picture. In this study, it was the participants, it was their first ever CVA, no longer than 8 weeks prior. Each had, and it was in the middle cerebral artery, like our patient. Each had severe hemiparesis, and some displayed neglect and aphasia. Patients were excluded if they had had a prior stroke or there was other comorbidities complicating the study. So there was 36 participants, 18 were in the mirror therapy group, and 18 were in the control group. The mirror therapy group did exercises kind of like the picture where they could see the hand in the mirror, whereas the control group did the same exercises, but they could see their affected extremity. And then at the same time, each of these groups were receiving the standard care for CVA. So this was kind of like an adjunct treatment. For the internal validity, again, you have the control and mirror therapy groups. So this was done for 6 weeks. They were seen 30 minutes a day, 5 days a week. And what they tested this, they did the Fugel-Meyer, both pre and post, as well as a test measuring the grip strengthening and graft strengthening. And what they found is both groups saw improvements, but the mirror therapy group saw greater gains in their distal musculature, as well as their reaching and grasping. Their light touch was improved, and those with neglect saw decreased neglect. Some limitations to the study was a small sample size, and it was only done on those with first-time CVA, so excluding the groups that have had them more than one time. Further research that might need to be done is that instead of just the upper extremity, they didn't do much testing, or they didn't do any testing on the lower extremity, so that might be something that can be done. And since all the patients had had their CVAs within 8 weeks, they didn't look at anyone in a chronic condition, so this might be another avenue that research can go down.
The article was on constraint-induced therapy, and what that it involves limiting the use of the uninvolved extremity, and this helps encourage the use of the involved extremity. The individual in the study that I looked at had very similar comorbidities and risk factors, and the study that I looked at was indeed a case study of a 69-year-old male who sustained a stroke in his left hemisphere. And the results of the study indicated that there was improvement in the subject's motor function in his right upper extremity, and that the outcome of that it warranted further studies, which were similar in nature but on a larger scale. The study I looked at, the repeatability of this study was something that was positive in that it had a pre-inclusion screen given to people who went through the hospital and had a CVA, and whether or not it was good. One of the negatives was the generalization of it may not be the greatest, because it was a case study and only one person was utilized in the study, and he had several comorbidities, so it could affect it somehow in that way. For the internal validity, the design of the study was, like I said, was pretty good, and it had that pre-inclusion screen as well as a protocol that the patient had to stick to. The bad was there was not really a control, since it was a case study, so there was no comparison on traditional therapies or anything of that nature. The clinical implications for this study, it shows that there's positive indications for using constraint-induced therapy during the acute rehabilitation process in someone who did suffer from a CVA. It was similar to our case that we were looking at with Mark. The subject showed improved function in his involved arm during the acute phase. And it also demonstrated that it may be helpful in the subacute as the subject continued to improve after he was discharged. This study was also useful in that the biggest gain seen was in his functional independence, and that's one of the biggest goals or objectives when treating an individual with a neurological problem. And but this study did need some further studies on a larger scale or at bigger populations. And you can see in the picture there, this guy, that's not an oven mitt, that's actually just a mitt that they use to help with constraint-induced therapy and improving the use of the uninvolved side or the involved side.
Okay, so the study I looked at the effects of aquatic therapy on postural balance and muscle strength in patients who had had a stroke. So this was a randomized controlled pilot study, and to qualify to participate, the subjects had to have unilateral limb weakness that was secondary to experiencing a stroke at least 6 months before the study. And they also had to be able to walk independently with or without an assistive device. So there were 25 participants. There were 13 in the aquatic group and 12 in the conventional therapy group. Each group participated for 1-hour sessions 3 days a week for 8 weeks. The aquatic therapy group, their program was based on Halwick and Aichi methods that the therapists were trained in these styles. So the Halwick method used fluid mechanics to enable the patients to achieve stability in the water, and the Aichi method involves relaxation and uses deep breathing and slow, broad movements of the arms, legs, and torso. So the main objective of this program was to improve balance, function, and associated with postural control. Then the traditional physical therapy group received conditioning and upper and lower extremity strengthening and gait training. So the results of the study showed that the aquatic therapy group improved in the Berg balance scale, but did not change significantly in the conventional therapy group. There were improvements in forward and backward weight bearing ability were greater in the aquatic therapy group. The gait ability measured by the modified motor assessment scale was improved in both groups. The torque of the knee flexor on the affected side increased in the aquatic therapy group, and there was no significant difference in trunk muscle strength between the two groups. So the overall results showed that an 8-week aquatic therapy program was effective in improving balance and strength in the hemiparetic leg in patients post-stroke compared to traditional therapy group. So the limitations of the study were it's a small population size and they had to be independent in gait, and it was more of a chronic stroke phase. So for future research, we want to use a larger sample size and more acute stroke patients that have more difficulty with ambulation.
The article was on music movement therapy, and the purpose of the study was to determine how the effect of music movement therapy would be early on in rehab for post-stroke patients, both physically and psychologically. What music movement therapy is a unique intervention that combines listening music, playing musical instruments, and singing, combined with traditional physical therapy for improving range of motion, strength, and ADLs. Researchers believe that listening to favorite or familiar music during rehab can make the exercises more tolerable and enjoyable, and also that listening to music activates regions in the brain that affect arousal, attention, memory, and other emotions. The design of this study was a quasi-experimental design. The experimental group received MMT for 8 weeks along with routine physical therapy, and the control group received only the routine care. Pre-tests and post-tests were completed, and a total of 30 patients completed this study, and the music movement therapy was broken up into 3 phases. So it was provided for 1 hour, 3 times a week for 8 weeks. The preparatory phase was 22 stretching exercises, which improve flexibility and range of motion. During these exercises, quiet meditational music was selected as the background music, and music therapists were involved to try and pick songs that were popular back in the patient's younger days. And researchers also displayed the lyrics so the patients could sing along. The main activities consisted of the patients playing musical instruments such as shaking tambourines with their healthy arm, and they also listened to and sang along while expressing their emotions. And finally, the finishing activities gave the patients a chance to make comments about their experience with the music movement therapy to enhance emotional communication. And all of these activities were completed in a wheelchair due to it being in the early stages of rehab. So the results of this study showed that the experimental group had significant results with shoulder flexion, increased shoulder flexion, and increased elbow flexion, as well as improved mood state. So the internal validity, there were some weaknesses found with some of the tools that were used to measure the outcomes. The muscle strength tool was the Medical Research Council scale, and it may have had a lack of sensitivity. The external validity, there was a small sample size, so that may want to be larger, and there's limitations with generalization of the findings because it was only done in one unit of a Korean hospital. So for future studies, some changes to be made would be to have a larger sample size, better measures for muscle strength and depression and lower extremity function, because depression wasn't, the scale that used for depression wasn't specific to only depression. It included anxiety, quality of life, and other factors. And this study mainly affected upper extremities and didn't really concentrate on the lower extremities function. So relevance of this study to the case is that music movement therapy can be very useful early on in rehab to improve range of motion and mood state for post-stroke patients. A stroke patient such as Mark, who's suffering from a negative mood state, might tolerate exercise better if it were more enjoyable, such as with music movement therapy. Patients in this study began their therapy within 2 weeks of onset of their stroke, which relates to Mark because he just had his stroke, he was 10 days post-stroke. So this type of treatment could really benefit Mark since he was still so early on. That's it.
Time for our clinical pearls. The first one is, as a therapist, you should be cautious if your patient is impulsive because they may decide to try something when you're not paying attention. So you got to be prepared for anything and roll with the punches.
You should be aware of your patient's psychological barriers to therapy as well as their physical ones.
Early risk factor identification is crucial in the management of one's health.
Keep in mind that the patient may be going home to an environment with another person with medical needs. You should plan your home exercise program accordingly.
It's important to remember that when you're starting rehabilitation early, and it's extremely important to help patients achieve maximum benefits.
Your non-traditional therapies, such as music movement therapy, mirror therapy, aquatic therapy, and constraint-induced therapy, are great considerations to make exercise more tolerable and enjoyable.
Here's our bibliography, and if you have any questions, you can send us an email.
Dang it, there was a